this is something that previous speakers at the end of the spectrum actually. So general practice is the first contact. So unfortunately, there's not much of research and collected data has gone into this. So it's going to be a very conceptual speak that I'm going to make without not much of facts and figures. But before that, I would like to enlighten you with the description of what is GP or primary care in the first time, because now most of these other presentations were at the in-house level, that is in ward ICUs and wards and theaters and all this. So general practice or family medicine or primary care this is what you get as a general practitioner. You're supposed to cover your patients with these basic underlined services whenever they come. So that provides a continuity of care, a coordination, and a very comprehensive. And in that, and there is a component called preventive care also, and health education. So the prevention is a sort of, unfortunately, is a little part of day-to-day practice of a general practitioner, where what we need at this screening and this septic forum is this preventive care of that service that the GP has to provide. So out of all these management principles that a general practitioner uses, this health promotion and disease prevention is what we discuss about today. So it comes as health promotion and disease prevention is not only infection, but communicable diseases, but it comes as non-communicable diseases also. I personally would say that most of the people are much interested in non-communicable disease prevention and health promotion at the primary care level. So I would like now in day-to-day practice, I would like to elaborate on the areas, types of illness or septic cases that we encounter on day-to-day basis. And mind you, in general practice, it is very tricky and very difficult because we see these cases in a very undifferentiated and a very early stage. So it is a very tricky situation to pick those things up and in the first contact when you see that. So when the commonest ones that we see are the respiratory tract infections, say coming on day 1 or maybe day 2, day 3. So they might go into mild to moderate diseases we see as respiratory tract infections might go into bronchopneumonias or bronchitis. And there might be red flags of sepsis presenting with cough, fever, and respiratory distress. And the other main components that we see as GPs are urinary tract infections. And especially in elderly, we always educate the other people, the general practitioners, to take it very seriously and about urosepsis especially in elderly. So they will come as confusion, fever, and hypotension. So at the extreme of life, the presentation also will be a bit different from a standard presentation. And the other types of common presentations of illness are skin and soft tissue infections, like cellulitis, abscess, or infected wounds, and all this. We see very much in primary care setup. So GPs tend to manage these mild to moderate cases coming with redness, swelling, and malaise. But we always recommend that you give a very early review date so that you can keep track of this patient. And the other type of infections that common ones are we get diverticulitis, cholecystitis, which might come as abdominal fever and signs of systemic infection. So anything out of all these lists, but they come in a very undifferentiated state. So as the first contact, and it's kind of difficult to predict which way they will head on to. So and the other thing is the sepsis in vulnerable groups. Sepsis in vulnerable groups are elderly patients, and because now sepsis will take a very quick changes and become very serious in elderly patients. So when you're seeing elderly patients, when you are seeing elderly patients, we give extra care, and we look for signs of red flags and signs of deterioration whenever we see them in our primary care settings. And the other ones also are immune compromised patients like diabetic patients, patients on chemotherapy, and cancer patients, and maybe HIV patients sometimes. So we need to we give an extra care when we see these patients. In the earliest signs of sepsis, we do whatever necessary to screen them and make them go into the proper place at the proper time. And the other type of patients that we see in general practice settings are post-surgical and post-procedure patients we see. And they come as, most of them then, their surgeries, as the previous speakers say, that even after admission also, they are being asked to follow up at the general practice or your family physician. So when they're being given a follow-up plan, so we make sure that we adhere to what is being asked and what is being recommended, and we carry on, because they always can go back to the previous state, or they can have another complication of infection after these procedures. And and the other thing is the pediatric sepsis. Pediatric sepsis, we see a lot of small pediatric age group children, age group. And this is also it's very tricky. These children might come as pneumonias or otitis media, or sometimes as meningitis, but they're very early stage. They almost look like the same. So when there are early signs of fever, irritability, and lethargy and rapid breathing, we always make sure that we give the margin of the benefit of that the doubt to the patient. And if the signs are there, we always make sure they go to the next level of care. So as you all understand, so this prevention is an important thing, as we all knew from very long time before. But early detection and management of sepsis is essential at the GP level, because now with all the presentations, what we gathered was time is the factor. So the delay, of course, can happen at this level, at the primary care level. Unfortunately, there is no uniformity in all the people, all these patients being seen all around the country. So because there's lack of training and lack of resources, so we find it difficult to manage very serious sepsis uniformly around the country because of those previously mentioned reasons. So I will discuss that. As you all know, what sepsis is, a life-threatening condition, as the general practitioners should know, the body extreme caused by body's extreme response to infection. And some key facts about sepsis prevention in general practice would be what we do is early detection and assessment. This is the recognizing symptoms is the key actually in diagnosing or management. So sepsis, recent infections, trauma, surgery, whatever the condition is, if it is they are having these symptoms of high body temperature, increased heart rate, rapid breathing, and all this, it's a warrant to send to the next level of care. And use of screening, you can we promote use of screening tools also to be more scientific on this. And we had a lot of discussion about this QSOFA and sepsis 6. But whatever the general practitioner sticks to a standard screening tool, that is all right. And prompt treatment of antibiotic, and we discuss about the antibiotic stewardship and all this. So there is a abuse of antibiotics, of course, especially at the primary care level, and that will lead to resistance, and the wrong antibiotic and the wrong organism will get into trouble once they are in the hospital setup also. So we always advise to minimize the antibiotic use, and whenever it is indicated, only to use. And with the antibiotic use also, review the patient timely and make the necessary changes if it's not answering the condition. And vaccinations, of course, at general practice levels, we promote for conditions like influenza, pneumococcal, and meningococcus especially. And number 3 is we very much emphasize on patient education. This we always try to include patient education as a part of every management of any patient. So patient, otherwise we cannot get the compliance, and we cannot build up a relationship, and we cannot have a safety netting on all these patients if the patient is not educated properly. So what we do is we make them aware about the symptoms of sepsis. If it is a case of sepsis, we educate about what is going on and what to be expected, and if these signs and symptoms are there, to come back or contact us for further care or for further management. And maybe educate them about the self-care and a general hygiene at their level, hygiene practices, which will actually prevent a lot of infections, and wound care, especially on diabetic patients, and proper management of chronic conditions, the NCDs and all, which might lead to sepsis at the end of it. And we do have a lot of chronic conditions at our clinics. And this practice of general practice or primary care does not mean that it's all these private GPs and all. This becomes actually should be heading towards all the levels of first contact care, like private clinics, OPDs of general hospital, any government hospitals, private hospitals, these family medicine clinics. Anyone who sees a patient at the first time is a primary care personality. So I think this message goes to all the people who sees them at the first contact. So this managing chronic conditions is another strategy of making taking preventive measures, like control comorbidity, especially with diabetes, heart failure, which can ultimately lead into serious infection. And if you the problem with the major problem with this type of patients are defaulting treatment. So if you can really get a compliance out of these patients and do a regular monitoring, you will be very much in control of the course of the controlling the condition and the disease. And another strategy we use is infection control measures. and wound care management. This is, of course, actually not to at a clinic level. This point is taken as clinic level. Even at a clinic level, what we do, we have to stick to our standards about this practitioner and the staff in a clinic. They have to have their hand hygiene and sterilization equipments and PPEs wear, because even from that clinic and then visit itself, the patient can contract a microorganism or an infection from the clinic, or the contact who was there in the clinic with that patient at that time. So we always try to prevent that part also, because even simple new influenza in a patient, another patient going into a immunocompromised patient will be very alarming to that patient. So that we recommend safe practice standards at the clinic level also, and wound care, these primary care physicians do, and we always ask them to do proper wound management, cleaning and dressing, and stand to very sterile procedures. If those facilities are not there, not to cater that, and just direct them to a place that they can have a proper care afterwards. And the next strategy.
Dr. Bihan,
Yeah.
sorry, a kind reminder that your time is up.
Right.
Yeah, we'll give you
just
one more minute.
give me only two slides. There's a timely referral, and effective communication is the other things that we can do to prevent very catastrophic outcomes. And continuous education and training, of course, is another thing that we agreed that the knowledge of the primary care the first contact person will lead to really good outcomes. So if there is an ongoing training, and these primary care people, general practitioners or family physicians are being updated, they will be able to manage them very productively. And the monitoring of the feedback is my last preventive measure. As previous speakers spoke about, when I make it my habit, when I refer some patient, I will always keep my records with the patient, and I will serially follow them up in that episode, and that makes easier for me to manage these cases of at the general practice level. So I think I have given a bit of outline of how we can prevent and what we do at the general practice level. So thank you very much for your time, and thank you very much for the opportunity given here. Thank you.